Welcome to The Kick, your expert-led podcast helping you explore and learn everything about getting pregnant, pregnancy, birth and becoming a parent.
On the podcast and our online pregnancy program, Grow My Baby, we share my experience of helping more than 4,000 babies to be born.
And our experience of running a women's health clinic and parenting 4 boys.
We're here to help everyone to feel empowered in pregnancy and birth with real-life practical information.
Welcome everyone, I'm Brigid Maloney.
And I'm obstetrician Dr. Patrick Maloney.
And today we've got a very big but great and juicy topic that we're going to do over 2 parts. And it comes from my own curiosity about people coming up to me and saying, hey, are caesarean rates increasing? Why is everyone having a caesarean lately?
Yeah, does it feel like everyone's having a section?
Yeah, and I think maybe it's just now that I've become a bit more aware of people asking me that question that I think, actually, let's dig deep and let's see whether it is true.
Look at the data, see what's going on.
Yeah, so I've had a very big look at the Australian Institute of Health and Welfare National Maternity Indicators. And
Well
if
done.
anyone loves data, jump on there. It's really great. You can really sort of interrogate it and get some really great answers. So
What does it say?
what does it say? Let's go. Pat, tell me, are caesarean rates increasing?
I think, well, the simple answer is yes. They've increased over the last 60 years unquestionably in a way that has corresponded probably with an improvement in outcomes, which we'll get to later on. But one of the costs of that has been a higher section rate.
And they sort of, now we're seeing some data that is differing between countries. And, you know, if we just consider sort of developed countries first, and we did a bit of a deep dive on the stats around Australia, United Kingdom and the United States. For everybody outside of those 3 countries, I'm sorry, it was just expediency. So let's talk about Australia first, Pat. What's been happening in Australia?
Well, I think if we look back way before my career into the 1960s, as few as 5% of deliveries were by caesarean section. And there were a big number of reasons for that, which I said we'll get to a little bit later. But really, it was a somewhat different cohort, a much younger group of women having bigger families. And so the rate was as low as 5%, but the outcomes were undoubtedly worse, and statistically, numerically.
And over time, that's sort of been just in rapid, well, sort of, it had a slow increase to begin with, but then a rapid increase in the last sort of, 10 years, hasn't it?
Yeah, and we think that rapid increase has been driven by a number of factors, which we're going to discuss today, but an older population of patients, people having smaller families, and a push towards, if you've had one Caesar, you're perhaps more likely to have another, and IVF and weight gain changes and so forth.
So in the 1920s, in the 2020s, like 2025, in Australia, it's up around 41%.
Yeah. And that's, that matches the numbers in a lot of public and private delivery environments in Australia. It's close-ish to the numbers in my own practice.
Yeah. And United Kingdom at the moment, and the only data I could really find was that about now 45% of all births in the UK are caesarean.
Yes.
And the States is lower, so 32.4%.
It's interesting, isn't it?
Yeah.
I wonder what the variation is there across the units in the US. Certainly there's a reputation for high levels of intervention in a higher socioeconomic environment and lower in a lower.
Yeah. So for someone like my mum, who was having her babies in the 60s and 70s, it would look like everybody's having a Caesar for someone who had their babies back then.
Yes, and I think this is probably the origin of the cliched grandma comment about why is it different? And it is different. They're right.
Yeah.
There are higher numbers. And I think someone having a baby by caesarean section, if it was 5%, then that would stand out for its rarity. And in fact, you may have hardly ever met someone who had their babies by caesarean section. And, at 5%, it was just about reserved for placenta previa, multiple, grand multiples, triplets or above, and people with significant pre-existing obstetric problems. I think one of the things that we have got better at, but the rising Caesar rate has been part of the cost of, is that we know about all those people in advance now. So ultrasound's got so good that we can pick all of these things, or just about all of them, so that a woman doesn't have to go through a highly traumatic and problematic first birth before she realises that she's got condition XYZ and have the remaining babies by caesarean section. These days we would know about that problem most of the time. And like someone with a big lower segment fibroid, for example, that's going to block the birth. But back in the pre-ultrasound era, you just had to have a baby, and then they realised it wouldn't fit out. And then they did a Caesar, found the giant fibroid and went, oh, well, there's your problem. But now we've got an ultrasound telling us that there's an 8 centimetre lower segment fibroid there, or a 15 centimetre lower segment fibroid. Baby's never going to get past. We'll just do a section up front.
God, that just makes me feel so sad for women back then, and we'll get on to the differences as well. And avid listeners will remember me telling the story about our little Catholic church when I was growing up in the 80s, and the one person that we knew who had her babies via caesarean, and then the whole congregation had to pray for her.
Had to pray for her. Yeah, well, I'm sure that was I'm sure that was a lovely thing to have done at the time, but it seems funny now, like that, because things
have changed.
Yeah, things have changed.
Yeah.
I'm Kate Langbrook, and I host No Filter. Celeste Barber.
Hi.
Welcome to No Filter.
It's nice to be here.
Yeah, today we're diving into the world of G-Flip.
And your voice has always been such a calming, warm energy. So that's why I tear up, because you're always growing up with you around. So thank you.
Sally Hepworth, what a absolute jewel you are in the crown of artists.
Oh, thank you. This has been lovely.
Today, we're talking to Rosie O'Donnell.
I just want to tell you, this is one of the best interviews I've ever had.
If you love conversations that go deep and stories that stay with you, listen to No Filter. New episodes of No Filter drop every Monday, wherever you get your podcasts.
So I do want to ask, though, and for those people that say, oh, my God, the caesarean rate is rising so dramatically, does this mean that we're doing something wrong?
Well, this is the great question. There are two ways of looking at this. We might be doing something wrong, i.e. we're interfering too often, or we might be doing something right, i.e. improving outcomes to the point where to have a baby in Australia in 2026 is, amongst the best data in the world, but also amongst the best data there has ever been in terms of maternal and fetal safety. But that's not the whole story. There is, quite apart from the safety argument, a natural inclination amongst our patients to want to have their babies vaginally most of the time. And so we're winning by some measures, but we're not winning by every measure. Yeah.
Well, let's talk about some of those measures. So you say that outcomes have improved. Maybe let's tell the listeners what happened in 1960s for the mothers.
Yeah, so maternal death is one outcome that is a horrifying outcome. We never want to see that happen. And, it's the hard case that makes the bad law because maternal death is rare. And if we reduce maternal death by making a massive intervention in pregnancy care, there are small numbers, and the reduction will be small numbers, and we have to always think we don't want that to happen to anybody. But with or without the intervention, the numbers are small. Okay, so in Australia in the 1970s, the maternal death rate was about double what it is now, but it was only 12 per 100,000 versus 6 per 100,000.
Yeah. And again, some people go, well, how many births in general? So in 2023, there was 23 deaths in total.
Yes.
So it's a very small amount. We
Yes.
obsess about it because it is such a terrible outcome.
Absolutely. We also have to look at what's causing those deaths. So some of them are, if you like, unrelated to the mode of delivery. So the hemorrhages, there's still a small number of postpartum hemorrhage deaths. There's a small number of deep venous thrombosis and pulmonary embolus deaths, and you could get those in either group. Yeah.
And can we hang our hat on the fact that it's half now on the rate of caesarean?
No, I think we can claim that risk reduction has happened through a number of different interventions, not just the rising section rate. And the major critics of the rising section rate would say some of those things we've improved anyway.
Yeah.
Yeah. So undoubtedly we're better at treating postpartum hemorrhage now than we were at the start of my career. Undoubtedly the drugs are better, the protocols are better, the teaching is better. The drills, we do drills. A quiet day in labour ward, we drill for the next postpartum hemorrhage.
Is there ever a quiet day in labour ward these days?
If there is, no, people just don't go and have a cuppa. We sit around and practice. The next postpartum hemorrhage, how are we going to run it? There's no doubt that all of that stuff is better. So you can't just say that the improvement has happened because we're doing more Caesars. Yeah.
I want to just pick up, if anyone was to Google to fact check us, please do, and then tell us whether we got things right or wrong, and we're open to all of that.
We're open to that.
But I did a quick Google AI on higher maternal mortality rates, and it says that there's high mortality in caesarean versus vaginal birth, and the World Health Organization, and it did have some reputable sites that
this
it was
quoting
maternal
Yep.
mortality. But it didn't differentiate between a developed and an undeveloped world. So, can we unpack that a little bit?
Yeah, I think the most obvious devil in the detail of that data is that if you were labouring away in a undeveloped country where you were several days away from surgical care, and you went into obstructed labour, and then eventually you were transferred to a district hospital, and from there to a city hospital, and this took several days, and you eventually had a stillborn baby by caesarean section, that may have terrible outcomes for you as the mother. You might go into septic shock and die, but it wouldn't be because you had a section. But you would be analysed as a death occurring in the section group. Okay, whereas if we look at someone having obstructed labour in Melbourne in 2026 and has an evening Caesar in the setting of no progress, that's an extremely safe intervention. Yeah.
And it's interesting because I did deep dive on this. You can't on the AIHW. You can't. They don't have how the death. They have how the death was caused, but not mode of delivery during that birth.
Yeah.
So you can't even see there whether it was a caesarean or vaginal birth.
Yeah. So in a developed country, the problem with looking at it in terms of maternal safety is that the numbers of poor outcomes for the mothers are extremely small, and there are statistical problems with analysing small numbers, and also that it's unlikely to be the Caesar that was the problem. Yeah.
All right. Well, what about babies then? Have we improved the data for babies?
Well, unquestionably over the same period of time through a number of interventions, the data for babies has improved. If you are born today, you're 6 to 7 times less likely to die in the first year of life than a baby born in 1960. And there would be so many reasons for that. Better care of prems would be a big one. But some of that would be babies being born in roughly better condition, because over that same period of time, we are reaching for caesarean section as a tool to be used more frequently in the setting where there's serious concerns for the fetal well-being during the labour.
And I know that, we are just focusing on infant or maternal death. And we're going to get on to other outcomes of birth. But, honestly, that's about the most data that we've got. It's weird. Like you try and look for other data and it seems like a inconsequential finding that, not really, but, we focus so highly on death.
Yes, which is
a nice, easy, round data point.
Yeah, which is probably not the best way to look at it. So they developed something when I was a registrar called the Robson criteria for caesarean section, and that was actually a way more useful tool to look at Caesars, in particular for the comparison of one unit versus another. So, for example, if you started up a tertiary referral unit in a big city hospital and you only treated triplets, then the appropriate caesarean section rate in your unit would be 100%.
Yeah.
Or if you only received referrals for placenta previa, 100% would be the only justifiable number. So that's not a fair comparison. So what this criteria system did was break down the Caesars into, someone will tell me, 10 groups maybe. And some of them were no-brainer Caesars and some of them were kind of Caesars that honestly you maybe had never had to do or you shouldn't have done or whatever. Shouldn't have done is the wrong way to put it. That it was arguable whether that was necessary.
Medically
and
needed.
Certainly groups where there's room for improvement. And that became a way more useful tool to compare apples with apples. So a unit with a high caesarean section rate, you might think, oh, that's worse. Well, no, they might just do way more complicated work. And so it was a way of comparing two low intervention, low risk units with each other in terms of the performance.
And do we still use that?
Yeah.
Yeah.
I think that's a way. Those sort of things are a way better system for analysing how things are going. Because if you look at placenta previa or triplets, we don't want to do less sections. We want to do all of those by section. So there's the group that we really want to look at is in labour sections for spontaneous labourers at term. There's room for improvement there.
Yeah. And for those people that might say, yes, but the World Health Organization says that we should be doing 10% caesarean sections. You and I have talked about this before. It might just be useful to, at least 10% caesarean sections.
Yes, I think that statistic is bandied about on the socials a bit incorrectly. I think that people say that the World Health Organization says it should be 10%. I don't think they're quite saying that. I think they're saying that there should be facilities in your country such that 10% of the babies could be born by caesarean section, because we know the outcomes are poorer at less than 10. So at less than 10, you're not catching all the people who really, really, really need a section. So they're saying that you basically need to have a level of at least that. And then when the levels are much higher than 10, we have to continually say, hang on a minute, are we continuing to improve outcomes by letting the numbers come up? And we may be experiencing a concept called the law of diminishing returns, where if you increase your section rate from 10% to 20%, you get a dramatic improvement in neonatal outcomes, but you may not keep on seeing that improvement when you go up to 30, 40, 50, 60. Yeah.
What isn't being considered in any of this, it's all very much medically based caesarean section, but there's also choice. So,
Yes.
People actually choosing caesarean section. I want everybody to know I'm not pro or against caesarean section. I'm pro-choice. So
Yeah, we're just discussing
we're just
choice,
discussing choice. Yeah. So, I mean, the question is, what point do higher rates stop improving outcomes from a medical perspective?
Yep.
But if a hospital's being run based on their caesarean rate, how do they factor in choice?
It's really interesting because in Australia, choice is much more commonly people much more commonly choose a caesarean section without a medical indication. remember, we've got to be careful when we use words like elective section and so forth. Typically, elective section, what we mean is it's planned, but it may have a perfectly good medical reason behind it. And so if we talk about a caesarean section for a moment that has no medical reason behind it and is just the woman's preference for how she has her baby, then that preference is much easier to get in the private sector than the public. So if someone comes to see me, I'll put my cards on the table. If someone comes to see me and says, I want to have my baby by caesarean section, I say absolutely yes. That is your choice. And we discuss the pros and cons, risks and benefits. But if that's what the woman wants, of course she can have that. In the publicly funded public sector in Australia, that choice does exist, but it's a little harder to get what you want. Yeah. You face more barriers, you probably face more people trying to talk you out of it, and it's harder to get the decision to have a planned section off the ground. But ultimately, you can.
I think you've oversimplified your consultation there, Patty, because I know that you talk to people about the reasons why they're choosing a planned caesarean.
Yeah, that's what I said. So you.
Oh, no, you said that you would go risks and cons, but there might be that there's a trauma that needs to be discussed.
So you have to, you're right. You have to look into it a little bit and work and just make sure that the reason the person is choosing a section isn't based on incorrect information or isn't something that they're doing out of fear, when you might be able to treat that fear differently. Yeah, so I've had a few people have changed their mind when they've been to the psychologist and talked about their fears and worked their way around it. But no, the point I'm trying to make is that if at the end of the day that's what the woman wants, then she can have it. That is probably going up a little bit. But I think it's only going up a little bit because people are starting later and having fewer babies. So let's say, for example, there was no preference at all out in the community for Caesar or vaginal birth. No, people didn't feel strongly about it. It was entirely up to you, and there was 50-50 with it, which however you want. Then one of the main reasons to avoid caesarean section was if you were going to have 4 or 5 babies. Because when we talk about the risks of caesarean section, it's a very, very, very safe procedure. But there are some significant risks when you get up to 4 or 5 Caesars in a row. And the scar related to the previous caesarean section can be surgically difficult to navigate. And there's a problem called placenta accreta, where if the placenta implants over a bunch of previous caesarean section scars, then that can be quite dangerous. So the main risk of Caesar is not that you'll be harmed by any of your first 2 or 3. It's that if you want 5 babies, there's a really big safety impetus to have them all vaginally. Whereas if you're 36 when you have your first and you only want 2, then you could choose to have 2 and statistically not run into the problems that apply to the 4 or 5. And it becomes a choice that you can make based on personal preference rather than being unduly worried about safety.
All right, Patty, I want to stop it there because you've picked up so many things that I want to talk about as to why we think that the rate of caesarean section is increasing. So I want to start our part 2 with talking about the maternal landscape and comparing it with 1960 to now.
Nice.
And I think that'd be a really great place to stop it here. And we'll come back with part 2 of are caesarean sections increasing in our community.
Perfect. We'll see you next week.
All right, everyone. Hope that was great listening. We'll see you next week for some more juicy content. Until then, keep well, keep growing those babies. Bye for now. Hey, even though Dr. Pat is, a doctor, and we get lots of other doctors and other experts on our podcast, I just need to remind you that this podcast is for informational purposes only. We share lots of medical insights and experience, but everything we talk about is general in nature and may not apply to your specific situation. Please always consult with your own healthcare provider for your individual medical advice when you grow your baby.